Good evening and welcome everyone. On behalf of the Lamb Foundation, it is my pleasure to welcome you to this evening's LAMposium in your living room. My name is Cindy Beasley. I am the Director of Education and Advocacy for the Lamb Foundation, and I will be your moderator this evening. This year's LAMposium in your living room series is designed to bring the sessions from the in-person 2025 LAMposium directly to you. Tonight, we are fortunate to have Susan Jacobs from Stanford University presenting on understanding supplemental oxygen, device options, and tips for staying active. Following the presentation and Q&A this evening, we invite anyone interested to stay online for a time of informal discussion, which will go until 8:30 p.m. Eastern Time. Now, before we begin, please note this session is being recorded. Microphones will be muted and the chat box disabled. At the conclusion of the presentation, we will open the chat box for your questions. And now, it is my pleasure to introduce our guest speaker. Susan Jacobs is a research nurse manager in the Division of Pulmonary, Allergy, and Critical Care Medicine at Stanford University. She oversees multiple clinical research projects aimed at new drug investigations to more effectively treat patients with a variety of lung diseases. Susan has led major efforts to improve oxygen services for patients, including authoring the first national survey of nearly 2,000 U.S. supplemental oxygen users. She was the lead author of both the American Thoracic Society's Oxygen Workshop Report and the Clinical Practice Guidelines on Home Oxygen Therapy. Susan works with policymakers and advocacy groups to address care gaps and founded the ATS Oxygen Special Interest Group in 2018, which continues to champion better access, device innovation, and education around oxygen therapy. Now, Susan also serves as a co-LAM liaison for Northern California and is a fan favorite of our LAM community. Susan, thank you so much for being here. I will now turn this over to you.
Uh, so thank you for joining. I look forward to sharing lots of information, and it is a lot of information, but do be reassured that this is going to be posted on the LAM website so that you'll all be able to access this information on whatever you don't catch. So don't worry about that. I might go through a few slides quickly, but I'll know that you'll have these at your disposal later on. So we're going to go through and touch on really about 6 areas. We're going to go through some of the basics, how we assess if you need oxygen, how it's prescribed, what type of resources you have at your disposal, and then some highlights of some oxygen research and oxygen advocacy work. So a little bit of everything. So I think the first thing to remind all of us about is that treating low oxygen levels is part of really a comprehensive management of any patient who's got LAM. So we kind of refer to some of these as non-pharmacologic interventions, but managing fatigue, knowledge, dyspnea, chest discomforts, deconditioning, but very importantly, making sure we assess and determine if you have low oxygen and we treat that. So a little anatomy primer here. Just understanding the oxygen that you inhale is coming in through your airway, the big upper airways, trachea, down to the bronchi, and then it really travels deep into the lung to these what we call terminal bronchioles. And this is kind of where the action is in terms of oxygen transfer. And so then you can see it goes from the bronchioles and into those capillary bed down into what we call the air sac, the alveolus. And that's really where the oxygen crosses from the air sac across that alveolar capillary wall and jumps into the bloodstream, attaching itself to oxygen. So that's the key, is getting that oxygen down into that bloodstream. So why is it that in some patients with LAM that oxygen is a challenge to get into that bloodstream? So sometimes that effective alveolar capillary membrane is affected because you've got cysts in the lung or holes. So it's destroyed some of that airway and some of that area that the oxygen can get into the bloodstream. We also find in lung diseases that sometimes the ventilation or the air that's coming in is not always going to the areas that has good blood flow. So there's what we call a mismatch, and that can also lower oxygen levels in the blood. And certainly if you have something that's compressing the lung or pushing on the lung, such as fluid around the outside of the lung between the chest wall and kind of squishing the lung. And of course, with the collapse of the lung, both those things can also cause low blood oxygen. So just how many patients with LAM actually have low oxygen levels? And this is a summary of just 4 studies that give all different percents. So it kind of depends on the study in terms of what they found in that population that they studied. So for example, there was a 2003 study looking at, this is actually Dr. Moss's and his group, at testing patients with really sophisticated exercise testing. But they had a population of 217, and of that group, 28% use oxygen with activity and 14% continuously. And another much smaller, just a descriptive kind of a focus group study, there were only 37 patients, and that group, a higher number, did use oxygen. It could have been that some sicker patients were involved in this group. We don't really know. And then another study looking at menstrual cycle and symptom variability had a large sample, 307, and it was about a third of those patients that use oxygen. And then lastly, more recently, the LAMPrep study with Maria Holtz, medium size, 67, still on the smaller side, but for that particular population, 39%. So you can see there's quite a range depending on what population you look at. So if your oxygen levels are low, what would providing you oxygen do? It may decrease your shortness of breath. It may decrease stress on the heart. We talk about pulmonary hypertension and avoiding that. The blood vessels want to constrict when they see low oxygen. It raises the pressure in the lung, and it can also impact the right side of the heart that's trying to push blood through the lung. So we want to prevent long periods of low oxygen. We hope that oxygen can improve your activity level, sleep quality, but I will say that, and even more recently, we do find that patient-reported experiences with oxygen vary quite a bit. That makes things challenging to study. So if you are prescribed oxygen because your level is low and you just don't use it, you may find with exertion especially, maybe your heart rate runs higher than if you were to use it. You may be breathing more rapidly. And I mentioned the blood vessels. You may have a little more right-sided work on the heart. But again, this last point, we really have minimal data on the effect of having you with low oxygen levels for short periods of time. So example, when you exercise each day or when you're active, we really have little long-term data. It may be that it doesn't affect you as we find with patients who have low oxygen when they're at rest. So it's really more of a 24-hour exposure to low oxygen if they weren't to use their oxygen. So how do we decide if you need it? First of all, we use objective data. You may be very breathless, but in fact have a normal oxygen level. So I get this question a lot. So if you're short of breath, it may not mean that your oxygen level is low, but it could be that you're sensing that greater work to breathe because your lungs have some airway obstruction. So for you to mechanically move the air in and out is a bit more work. And that tells your brain that it's working hard, the lung is working, and maybe you're not getting the air you think you should be getting for that effort. It's a very dynamic interaction between the brain and the lungs. Certainly, if you had fluid around the lung, it can cause shortness of breath, and your oxygen levels might be okay, but at some point they might drop. If you're deconditioned, you can definitely be breathless and have normal oxygen levels. So muscle deconditioning it contributes to breathlessness as well as any extra body weight. And of course, anxiety and panic can play into kind of worsening that breathlessness. We measure your oxygen level most of the time indirectly, as shown by this oximeter here on your finger. It's really just looking through your nail bed into a capillary. And we can do that with a walk, a 6-minute walk. It's a more formal test we can talk about a bit, or what we call exercise oximetry. We can do it continuously in the hospital, overnight at home. We can put it on a finger, an earlobe, or the forehead, which is actually quite sensitive. We rarely do a blood sample out of an artery, but it is done as needed. So it is important to remember that we're going to assess your oxygen level under different conditions, at rest, with activity, we call exercise oximetry or the walk. During sleep, we can put an oximeter on your hand, on your finger, a specialized one. You sleep with it. It's picked up by your medical equipment company, oxygen company, and downloaded to a computer, and it gives us an oxygen saturation just about every minute overnight, so we can assess oxygen levels. And we can also simulate altitude, which is important. We actually would have you breathe in a low oxygen content out of a large container. So normally we're at 21%. We would do this test on maybe 17%, which could mimic, for example, flight, which is at about 8,000 feet, or travel to altitude. So how do we prescribe the oxygen, and what equipment could you get? I want to first emphasize that the oxygen prescription varies worldwide. It even varies a little bit within the US. For example, our VA hospitals don't routinely provide portable oxygen to patients who only desaturate with exertion. And then internationally, that's more common. So Australia, New Zealand, Canada have rigorous requirements that you would have to actually walk with and without oxygen, and document changes in breathlessness, distance walked. Some even do it on a sham, you won't know what you're walking with, room air or actually oxygen. So it does vary around when we prescribe portable oxygen with exertion. In the US, we do qualify, patients do qualify for this, but as I mentioned, VA hospitals are a bit of an exception. And it's really important to get an oximeter. They don't have to be very expensive ones. You can buy them locally or online, but do make sure it's a quality one that you can see the sensor, and be just aware that skin tone, movement, nail polish gels can affect it. And the most important thing is the trend. We really want to know change. So you should kind of get to know your normal levels when you're quiet, and then when you're doing your normal exercise, so that when things change, you can let us know there's been a change. So this is showing someone doing a 6-minute walk. We would walk a patient. If that saturation falls below 89% and it hits 88 and lower, then we would do a titration walk, because now we want to know how much oxygen it takes to bring your level up over that, usually 90%. So in this patient, you can see it took 4 liters till they reached that kind of safe zone. So what are your choices for equipment? And again, this is varies, of course, on what your oxygen company can provide you, what your needs are. Are you working? Are you traveling? Are you dealing with 4 flights of stairs before you get to your home, or even within your home, do you have stairs? Are you unable to lift a heavy container, or do you have, joint issues? So we got 3 choices. The first one is compressed gas, and these are the green tanks that you see typically out and about and in the hospital. This is compressed gas. They come in many, many sizes. You can see here it's from tiny little wine bottle all the way up to 5 feet tall. They can be pulled in a trolley, and the smaller ones can be put in a portable carrier. And these can be on continuous flow or on pulse flow. You can put a different regulator on them, and we can talk about that. And then we have the portable oxygen concentrators, as well as a stationary concentrator. So these come in every shape and size. The bigger ones are, 20 pounds, and the smaller ones can get down to 5 pounds and less even. And then for the home, there's a stationary concentrator. This is, it hums along. I'm sure many of you who've used it don't appreciate the noise. And there's also a model we call a home fill, that you can actually plop this device on top, and it will, you can put a tank in there here, and you can fill your own tanks at home. They take a bit of time to fill, but you can do that. It's an option. Oops, I'm sorry, I skipped. And then we have liquid oxygen. So liquid oxygen is rare now because of multiple factors, and we'll talk a bit about our SOAR Act legislation, which we hope will help bring it back for those who need it. Liquid oxygen is super cooled down, so it takes less space. You can fit more oxygen in a smaller space. It can be carried in a canister, and it has a home reservoir that you can fill your canisters at home yourself. So again, it's what meets your lifestyle, but unfortunately, that's balanced, or I should say restricted by what's available. So right now, this third option is really rarely available. So compressed tanks, compressed gas tanks, many sizes, home fill or transfill, and these can go high flow. So you can put an E-tank on 6-10 liters per minute, continuous flow. It won't last long, but you can use numerous tanks as needed. And then the concentrated oxygen we talked about, stationary or portable. The flow rates, very important. We want everybody to understand that some of these work on pulse dose or demand, and some work on continuous flow. In general, the main message is that most POCs only work on pulse flow, and they will not deliver more than a total of approximately 2 liters per minute, even if they're on a setting of 6, 5, or 4, or any. That's the pulse dose setting. It's not a liters per minute setting. And this is something we work a lot with patients and clinicians to try and clarify. So there's also different types of flow delivery on the pulse dose. We call it minute volume. So no matter if you're breathing 20 times a minute, that minute volume won't change, but the amount of oxygen per pulse that you receive will go down. So the faster you breathe, the less oxygen per little bolus, but the total you receive each minute is approximately the same. That's getting into a little bit of technology, but I think it's important to know that a POC setting of 4 or 5 or 6 does not equal a continuous flow of liters per minute. That's the bottom line. So again, this is just reiterating that and showing you a regulator. This is what a regulator looks like down here. You can set that. Some will switch between pulse dose and continuous flow, which is nice. So when you're sitting, you could turn it to pulse dose and conserve. And then when you know you're active, you can turn it to continuous. This is a great guide that Mary Kitlowski and the so Running on Air organization. It's a guide to POCs. And again, you'll have the reference for this on my slides and you'll be able to get it. You can't read this, but I can just tell you by the color here, these are all of the settings in liters per minute. These are pulse dose settings. The total liters per minute you can see are all less than 2. There are 2 or 3 models that do switch to continuous flow. They're rare to find. So there are 3 portable oxygen concentrators, 2 or 3, that you can run on continuous flow up to 3 liters a minute. And they're about 20 pounds and need a trolley. So again, they come in many sizes. Battery life is shorter the faster you breathe. It's shorter the higher setting it's on. These are approved by the FAA. You really should be tested on these devices before you purchase one for certain, or take one from a DME that you can't change back later, just to make sure it works for you and keeps your saturations adequate. This is just how the concentrator works. It extracts air from the ambient air around us, and that air enters and goes into a sieve bed. This is the sieve bed, and it basically extracts nitrogen and ends up spitting out fairly pure, not 100%, but high oxygen after it's been purified. And this is just a picture of a liquid oxygen setup. Again, it has the ability to provide a larger amount of oxygen within a smaller space. These devices can deliver very high flow at continuous flow. The reason mainly that they're not available is that the cost. So they're more frequent delivery. A driver has to come out every week with a very specialized truck, trained driver. It's longer times to service patients. It's just generally a higher outlay for companies. There are also a couple of pendants and oxygen cannulas that can help increase kind of make more efficient. It provides a little dead space, a little reservoir, not dead space, a little reservoir of oxygen to collect so that you can inspire a little bit higher concentration. Can't use these with pulse devices. And there also are high flow cannulas. So it's just nice to work with your provider. If you are using a tank, for example, and it's not lasting as long as you'd like, you could ask if you could try an oximizer pendant to see if you might be able to keep your saturations up and have that tank last a bit longer. So some other tips. I mean, this is first one isn't really a tip. I mean, we wish we could say use liquid because the e-tanks are not user friendly. They're heavy, they're burdensome. You need many of them if you have high flow. But if your POC is inadequate, we want you to be oxygenated, especially if you're down in the low 80s and or lower. We really don't want you having long periods of low oxygen levels. So do take care to communicate with your care team. Let them know when your equipment at home is not keeping your saturations up high enough. You can have a high flow stationary concentrator. It goes up to 10 liters if you need it. It needs a physician order. Um, some patients will pay out of pocket for a POC and use their e-tank, for example, for high flow activities. And then the POC, we call it your shopping oxygen. It's if you're sitting, visiting at a restaurant, you might be able to be fine with your oxygenation with a POC. But Medicare and insurers won't give you two types of portable systems. It'll either be compressed gas or it'll be a portable concentrator. So that gets a bit tricky. So really watch your saturations and let those be your guide as to how your needs are being met under different conditions at home. So this is being creative. This is Bev, who's very creative. Bev Jackson, who just, this is her garage. We love seeing her garage. She's very creative and trying to be active, and we encourage everybody. We have examples that we show to our legislators and such with, this is not portable, right? This is not portable. And then we have the ultimate creative. This is a patient of ours, not a LAM patient, but she's an avid swimmer in the San Francisco Bay. And as her disease progressed, she kept swimming with her, I believe this is a compressed gas tank, sitting on her kickboard, I'm sure wrapped. I couldn't actually get all the picture there. Definitely look into support groups, pulmonary rehab, and work with your clinicians. If you need tanks and you are active outside the home, whether it's work, caring for family members, whatever it is, you advocate, we will help advocate to get you more tanks per week to let you get out of the house. Flying, the very long topic. I'll just touch on this because there's some other resources, but it is simulating altitude. And the FAA does allow almost all, and there's some caveats that we'll check. Do go on their websites well in advance, arrange for their forms and such to come to your medical providers. Make sure you're what we call fit to fly. We want to make sure you haven't had a recent infection, pneumothorax, any other events that you're maybe not completely resolved. And then when you get to your destination, do you need oxygen set up there? So really the key message is start planning early. Now for patients, and this was one of the questions I got earlier, if you only desaturate with altitude, in general, insurance does not cover portable oxygen for that. So you would still need to get a physician order, but unfortunately you would need to rent a POC to travel, and they're not cheap for rentals by the week. But insurers at this point are not reimbursing us, you, for use of oxygen only at altitude. In other words, you don't pass a test in the hospital. Even if it's a high altitude test, it's still, in our experience, insurers haven't paid for it, which is too bad. But depends. If some patients have vacation homes, for example, at altitude, they have to purchase their own equipment. So we're hoping that would change at some point, but at this point, and I'm happy to hear from others' experience, maybe there are those of you who have had success with this, but we have not. There's some recent information about batteries. I won't go into a lot of detail, but there was I want to say fairly sudden interpretation by the FAA and at the airlines that they were not allowing patients to take double batteries on flights. And the reason was they interpreted that double battery exceeding the FAA requirement of 90 watt hours. Basically, a double battery is two 98-watt-hour batteries sitting next to each other. You can't separate them. There's a picture there. You can't pull them apart. But the FAA interpreted that as exceeding their requirement. So we had patients that were stuck all over, some out of the country. Sometimes they were let on the plane from San Francisco with the double batteries. And then when they were returning from another state or out of the country, they weren't allowed to use those double batteries and had to use single batteries. And it was very challenging, not good for a lot of patients. So we have our advocacy groups working with the FAA and airlines to come to an agreement, and we've had some success so far to treat the double battery as actually it is two separate batteries that do meet criteria. So again, the message, always check with your airlines if it's okay to bring a double battery. This is just some other tips, I guess, warnings. We've seen in our ATS group reports by multiple providers and some of our RT and nursing members that patients have been buying some, we call them non-centrators online. So basically, if it's too good to be true, that it's only 4 pounds and it provides 6 liters and lasts 4 hours, it's not true. And we've had these websites, patients purchase the equipment, and when it doesn't function, they go back, the website's gone. So again, please don't purchase anything that's not FDA approved or that you haven't run by your care team, or just reach out to see if it's really reasonable. We do want you to make sure before you pay out of pocket for a POC, which can be $2,000, $3,000, $4,000, that it's adequate for you and that it's a brand that includes warranty for maintenance, for the replacement POC if yours breaks, and it can access to repairs. This is a problem if you're buying a POC from either an individual or off the website. We see that. If you buy it, there's no way for you to take it. We have found that patients can't find another company that will take that POC and repair it even or maintain it. So that is, we don't recommend it. It's very challenging because of the expense. But you don't want to be stuck with a POC you paid for and then there's no way to service it or repair it if it doesn't work. I've included a great website on our resource list that you'll get, No Person Left Behind, and I would ask that you all review it. We all should review it. It's just some basics if you have oxygen in the home. We really want you to notify your local fire and police department. So if you lose power, you're first on the list that they will check in on. Certainly if you have 20 e-tanks in your garage, the fire department wants to know that if there's a fire and before they get near your house. So very good to let them know. So for education, the good news is there's some outstanding resources. Many advocacy groups have wonderful resources online. So even before you go online, really try and get education. I know this is challenging. Our survey that Cindy mentioned, we found that of those 2,000 patients, 70% of them got their education from the driver, the truck driver who delivered their equipment. And many patients don't get training and family members. So make sure that if you are starting your contract, getting oxygen for the first time, you insist that they train you, your family member. It's not just dropped off and they leave with, a 30-page booklet. So do make sure you fight for some education and training. Do know exactly what your oxygen prescription is at rest and exercise and sleep. And make sure, if possible, you are tested on the equipment that you're given. This is something that's also part of the SOAR Act. I'll put a plug in again to get respiratory therapists funded back into what we call DMEs, the Durable Medical Equipment Company. We want those professionals there because they can test patients and make sure that the equipment is adequate. As clinicians, we like to have that person to talk to on the phone when we have challenges with a patient. And we have seen a loss of respiratory therapists for the last 10 years, really 5 to 10 years in the DME companies. So we really want them back. And this is another reason that they could go to the home and test you on your equipment and train you and teach. Learn about exercise and how to individualize your oxygen. And then, of course, a lot of people talk about having that main person to talk to at your DME, at your oxygen company. It's always nice to have one number you know exactly who to call. They kind of get to know you if possible. It's kind of a good approach. So this is from the LAM website. They have a great section on oxygen. This is the American Lung Association. These are numerous videos as well as, and I should say there are videos also on the LAM website. So again, the Lung Association, the Pulmonary Fibrosis Foundation, all three, and there's others, but I just mentioned these because they're kind of, I know them well and they're great access and in different languages. And these are the resources. Again, you'll get these. There's a lot of resources. We really struggle with the fact that there's so many resources for patients, and yet patients and clinicians aren't aware of them. So we really want you to be aware of how many great resources there are out for you, both in writing, videos, exercise videos, all sorts of things. Okay, I'm doing okay on time. We're going to focus a bit on research. So why do we prescribe oxygen? And really, our prescriptions today, especially for patients with what we call chronic hypoxemia or resting hypoxemia, as it's described here in this first section, is really based on findings from two studies that are really, to do my math, but I think 40 years old. So these two studies studied COPD, that's chronic obstructive pulmonary disease patients, and they looked at, they actually were two groups. They compared survival. So they found this was a long study, and they found that oxygen, and then a more recent study found there was no difference between using it 15 to 24 hours. But in general, they found that patients who use oxygen 15 to 24 hours a day, and it was closer to 24, their survival was significantly improved over patients who did not use oxygen. Again, these were patients that were pretty sick. You were sitting in a chair quiet. They had a saturation below that 89%. So that is the basis we really prescribe oxygen today. So since then, there have been many studies. But the bottom line is in the second section here. Trials for oxygen testing are very hard to enroll. For example, we could not replicate that study done in 1980. We couldn't now say, okay, you have chronic hypoxemia, you're hypoxemic at rest. We're going to randomize you to receive room air and another group to receive oxygen. So that would be we wouldn't be able to do that ethically. So and the other challenges, so it's difficult to enroll any kind of study. It's just laborious and it's got equipment. We also find that even though the results might find that a patient who used oxygen compared to room air doing a 6-minute walk, that they had significant improvement, that does that transfer to what that patient does at home? Do they also say, I'm able to do more at home. I have more energy. I can do more activities of daily living. We've had a hard time equating those outcomes. And then we have a question, who is it? If not everybody benefits from exertion, who has only low oxygen when they exert themselves, who are the patients that we should be focusing on? Is it the patient who desaturates rapidly when they stand up and go across the room, even though they started okay? Is it the patient who needs 6 liters, not just 2 liters to keep above 90%? Is it patients with LAM or pulmonary fibrosis or emphysema? Are they all different? So this is kind of areas of research that we need more studies. We also don't know if that finger reading really represents low oxygen at the tissue level. That's what we really want to worry about, right? We don't want damage to the heart muscle, for example. And we also find patients respond differently. We have patients that will say, oh, I can't leave it. I can't do this without my oxygen. And others come in, it's like, it's a burden. I don't find the difference. And then the balance, it's not worth me dragging this around or worrying about running out of oxygen. But it's very individual. We hope to find, and there's some work looking at this, what we call clinically useful biomarkers. Is there a blood test we could do that would show us that one patient group is suffering damage at the tissue level and the other is not? That would help us decide who to give oxygen, more aggressively. And what is the most important outcome? Well, for most patients, it's survival, but we also want to look at quality of life and function and ability to do things. So this is just kind of a look into the research challenges and what we actually need also going forward. We talked a little bit about this. What are the benefits for the exertion-only patient? And this is where we need the most research. Our guidelines actually only had a weak recommendation for use simply because when we looked at the research, there wasn't much to look at. There weren't many studies done. And the studies that were done were on smaller groups and not really definitive or had mixed results. One would be positive and one would be negative. This is the survey that Cindy mentioned earlier, and I just want to highlight that we looked at many groups of patients. You can see COPD across the bottom here. There's a lot of abbreviations, I apologize. Chronic obstructive pulmonary disease, interstitial lung disease, other alpha-1 antitrypsin disease, it's like a genetic emphysema, pulmonary arterial hypertension, LAM, and then the total. So even though the LAM patients, I know, were one of the smaller percents of the whole group, they reported the highest problems when they were asked, do you have a problem with your oxygen? And I think it's because that your population, LAM patients, are a bit younger, they're active, they're in the middle of multiple things, whether it's young family, older family. I think they're just a generally more active group, and it showed. So device development and research, we wish we had more innovation going on, but thanks to Dr. Moss and Bev Jackson, and I know there are others, and I'm not thinking about them now, but some LAM patients worked hard, and this is a small business innovation research grant, successfully funded, which is a huge accomplishment, and now is in year 2 for the development of a lightweight, longer battery life, higher flow capacity, and FAA compliant. So we will wait for that next phase. There are also some auto titration devices on the market, meaning that you would have a pulse oximeter, and it would, based if your saturation, like you got up and we're now going to walk through the market or wherever you're going or exercise, it will have a feedback to your tank, and it will tell your tank to increase to 6 liters a minute. So this is actually a study that was done. It was just a very pilot study. So not a lot of patients, and it was a COPD, and the diagram's a little tricky here, but this is a cannula, high flow cannula, a wrist oximeter, oxygen cylinder, and a closed loop device. And they had this person get up, stand up, walk, do some weights up and down on a shelf. And they looked at how this device went from the flow rates at sitting. And then all of a sudden, right, the saturations dropped. So the flow rate went up. And then they probably went up more. And anyway, this has just been published recently. So this was just a very early pilot. It was a randomized trial, and I found a significant difference. Whether it interprets or coincides this significant difference in daily life, we'll wait to see. But this is a start. It's a great thing to see in process. It would help your tanks either last longer or give you more adequate oxygen throughout the day, so you're not dipping up and down. I want to end, I'll leave some time for questions, with advocacy and talk about the SOAR Act. So you can see there's a lot of unmet needs, I think, with oxygen, but really what the SOAR Act is addressing are 4 main pillars. And the first is ensuring that it's patient-centric. So the first thing we want to change the thinking of lawmakers and Medicare. This is not home oxygen. This is oxygen to help our patients get out of the home, and includes a Bill of Rights so that you have the right to be trained on your equipment. You have the right to have it maintained as the contract says. And you have a right to be given equipment that meets your lifestyle. If you have stairs, then they need to accommodate that. If you have high flow, you need more tanks. The second is ensure access to liquid. So not all patients need high flow. So we have a clause for whom it is medically necessary. And this really means that for patients who are outside the home, whether that be work, travel, getting a loved one to medical appointments, taking care of either older parents or relatives or younger children, if you need high flow, which is roughly, I think we said over 4 liters a minute, 4 or 6 or higher, I'm sorry, 6 or higher, you would be eligible for liquid oxygen. The third pillar is getting adequate reimbursement to respiratory therapists. As I mentioned earlier, we really want them back in the DME setting so they can be into home as well. And then the last is just having a standardized order template so that we can order oxygen without the providers or the education, the oxygen providers or the insurance companies back and forth looking at medical records. We want a standardized template to streamline that process. And this is just an example of advocacy letters. There are many, many of us advocacy groups working on your behalf every day, every month on the Hill. And of course, getting this legislation, which is now there's 2 bills, one for the Senate and one for the House, slowly making its way. It's just had a hearing. So we're hoping to have it included in the end of year or early year healthcare bill. So this is actually a QR code. I'll leave it there for a few seconds. If you go on the Lamb Foundation site, the link is there. There's also lots of information on SOAR and on oxygen legislation, templates for if you pick up the phone, what to say, if you want to write a letter, what to say, lots of resources. And also this is from the Pulmonary Fibrosis Foundation as well. So with that, I'd like to summarize the top 6 points, I guess. Definitely use an oximeter, get to know what your normal is and keep track of them. I don't want you fixated on it, but just know your normals and when things change. Definitely work with an oxygen company with every effort, and we will help you and advocate for you to get the equipment, supply, and training you need. I didn't talk a lot about exercise, but exercise, exercise, exercise. So whatever it is that you do, walk, pulmonary rehab, virtual rehab, LAMFit, which Mary Beth Brown's been involved in, yoga, water aerobics, anything to get moving and get the oxygen that you need to enable you to do that. Please get education and support. There's lots of resources, and we would love to have you participate in research, all kinds of research, drug research, device research, and lastly, and most importantly, advocate for SOAR and also NIH and other research funding and device innovation. So with that, I say thank you very much, and I will stop sharing and take questions. Hope that works.
Yes, thank you so much, Susan. Let's see here.
You're welcome.
Okay,
I'm
yes,
mainly glad that my internet didn't die.
I am too, and the sound was perfect, so it was great. But oxygen supplementation is really an area that the majority of us with LAM are going to deal with at some point in time. So this is such an important topic for our community, and the work that you put into this, the way you share your knowledge and your advocacy, just know how much we appreciate you and appreciate the work you've done. This is really, I learned a lot tonight, and I have my little pulse oximeter right next to me while you were talking, and I was looking at my stats. So there you go. So at this point in time, we will open the chat box for questions. And somebody had asked, what is LAMFit?
Oh, so, and others can jump in and remind me, but LAMFit is an virtual exercise program that Mary Beth Brown, who is I believe, a PhD physical therapist, and I think she's up in the Washington area now, Washington State, and she developed I don't want to say virtual, but it's an online, so you don't have to do it in person. And it was a research protocol where she had LAM participants enroll. I forget the randomization if they had different arms, but this was a home-based exercise program, And I think her first, and I'll correct myself if I'm wrong, but I think her first phase showed a significant difference in improvement in exercise. And I can't tell you honestly if she has a current active enrolling protocol or not. But
I
I
can tell you, I can
actually,
answer that one. Yeah.
okay, I was going to
Mhm.
actually ask her to talk to our next liaison, our next Region 19 meeting. But go ahead.
Great.
That's what I know.
Yes, so you are exactly right, Susan. And this has been in development for a while. The Lamb Foundation has supported this, and they are now in their phase 3 of working on this, and they're testing out an app and trying to figure out a way that it can become available to the broader public. So stay tuned for that. We do have a video on our website about LambFit if you're interested in learning more. Beth, in fact, there's a couple presentations that have been given on LambFit. So it's a great option, particularly for folks who don't have access to pulmonary rehab, and it is
Yes.
specifically designed for Lamb patients. So, all right, do we have another question? More on travel to the U.S. for non-U.S. Lammies. No company would allow me to pay individually since I don't have U.S. medical insurance. Why not? So can you speak a little bit to kind of these maybe there isn't an answer, right, on why oxygen gets paid for. It does get paid for, particularly for international patients. This is a challenge.
So this sounds like an international patient trying to come to the U.S.
Hmm.
I mean, so I can speak the other way. So for our patients, and this is not just exertion only question. This is in general trying to get oxygen for flight. Because if this is a patient who doesn't normally use oxygen except during flight, if they're in the US, they actually would have to get a doctor's order to go to a company and pay out of pocket to rent a portable oxygen concentrator to take onto the airplane with them to fly. And I didn't mention that when you do fly with a POC, you need battery life long enough for 1.5 times the hours of the trip. So if it's a 4-hour flight, you need 6 hours of battery life duration. Um, oh, I see. I use oxygen 20. Whoopsie, I just saw that in the chat. Sorry, I'm trying
Yeah.
to look at the chat at the same time. Um,
She needs oxygen to spend time in the US. She has a portable for air travel. So would she be able to rent? I'm not familiar with these rental services, and I know that we had somebody had asked that question about Inogen has started their own rental service. Can you, talk a little bit about that? If it's available, can we pay out of pocket? Do you have to use insurance? What does that look like?
I'll be right back.
Okay. Yep.
Cindy,
Yes.
I can tell you the perspective as a Canadian coming to the
That
States
would be
using
wonderful.
oxygen.
Thank you. Yes. Hallie, thank
Um,
you. Hmm.
I had a prescription for oxygen, so I had everything that Susan has talked about. I was lucky I was able to sort of double dip. I had cylinders, I had POCs, I had big machines. Anytime
Hmm.
that I traveled, I wasn't brave enough to go with one POC, so I rented a second one from the company that provided my cylinders, and
Hmm.
I also rented extra batteries. So I would take two of POCs with me. God forbid something happened and I was wherever. So I
Right.
was able to rent them here. Um,
Hmm.
I don't know if that's an option for other people or not. Does that answer the
And were
question?
you, yeah, I think so. Were you able to rent when you were in the US
I
as
rented
well?
here and took
You
them
rented
with
in
me. I've
Canada.
never ever tried to get something out of Canada. I've always taken it
Hmm.
with me.
Hmm. It is an interesting question to know, right? If you're coming into the US, can you access oxygen by doing individual pay? So,
I
yeah.
know that people that go on cruise ships,
Hmm.
there are companies that you can contact and they will have concentrators on the cruise ship for you that you can
Hmm.
use. I
Hmm.
never did that, so I don't know what system they used, but I have heard of people doing that.
Right. Right.
I don't know if that helps.
Good. Thank
And
you.
I believe they're very, very expensive.
Is that right? Out of pocket,
Um,
Sharon? I think.
when
I
I
tried to
rent, sorry, go
I
ahead.
tried to rent a go ahead,
Sharon, you're coming in
Hallie.
and out. Yeah, we can't hear you.
I know. I tried to rent a Oh, okay. Sorry.
I'm going to jump to Allie Venagopal for a minute, and then Karen, we'll come back to you. Allie?
Yeah. Hey, Cindy, thank you. And hey, everybody from NIH. I'm here with my new friend Belachi, and she actually has a question she wanted to ask.
Hi, my name is Belachi. I'm at the NIH. I did the 6-minute walk test yesterday, and it started off with 98, then 97, 95, 93. The last one was 89. So Dr. Moss said 89. So the last one dropped to 89. During my 6-minute walk test, he scared me. He says, I might need oxygen later on. I got nervous. That's my question.
Okay, you know what? I'm going to have you hold that question and that thought for our next session when we have an informal discussion, because I think it's a really important question. It is scary, right? So how have those folks who have kind of walked this road before us, how have they dealt with that fear? So can you hold on and stay on with us for about 30 more minutes?
Yes.
After I close it? Okay, perfect. Let's do that then, because I think that will help answer your question. And I'm not sure what happened to Susan, so I am a little nervous. Let me see if there are any other questions. Does anybody know, those of you who are oxygen users in our group, are there any POC type devices that are continuous flow? I think Susan mentioned that there were 2 or 3.
Mhm.
Has
There
anybody
are a
used
few.
that?
Yeah.
I
Yes.
have one.
Okay. Can you tell us about it?
My personal POC is Simply Go by Respironics. They have one that is about 10 pounds. It's a little bit larger, but it goes up to 2 liters continuous flow, and it goes up to a pulse setting of 6. And it does
Nice.
come with a cart, but again, I'm usually able just to carry it with the shoulder strap, and it's fine.
Wonderful. Yes. And somebody else had mentioned that Simply Go. Somebody has an OxLife Liberty 2 that can switch between pulse and continuous up to 2 liters as well.
So
that's
and the Liberty 2, it has, you can switch between the two. It's about with the battery in, like about 10 pounds as well. They do make a cart for it, but I usually just carry it. I
Okay.
have a backpack.
Good to know. Good to know.
I'm back
Nancy?
here. Cindy, can you hear me?
Oh, wonderful. Yes.
I'm so
yes.
sorry. I think
No worries.
So I'm happy to continue and just keep answering. So go ahead. It sounds like you're
Great.
a lot
So
of knowledge, I think, within this group about this. So it's great they're sharing.
Yes, it's been wonderful. We've been jumping in, and we did have one question kind of about the psychological difficulty when you're first diagnosed with oxygen. And so I thought that would be a really appropriate question to talk about in our smaller group, unless you have some insight or thoughts on that as well. But it can be frightening, that initial diagnosis. So
No, it is, and the thing with oxygen is it's just so visible, right? It's such a
You took 2.
it's just there's no way, and I think
Did you pay for one?
I think the
Take
perception
a-
is that person can't do as much, for example, or it just
right.
but we really want to dispel that being on oxygen allows you to do more, but there's no getting around that adaptation. It's a big change for patients.
Right.
And family and people around.
So somebody has a question here. They said, I don't qualify for oxygen. However, when I exert myself, I feel like I'm struggling to breathe more than what I feel is normal. It's worse in the winter, which I heard today. Somebody was talking about how actually the cold constricts the vessels in our lungs, which is why that happens. I do have mild asthma and use a puffer daily. However, are there other options to get more air somehow? I sometimes stand in front of a fan if available. So any thoughts on that? For those of us who are just kind of on that edge, right?
Right. So I think, I alluded to some of that on that slide about the work to breathe. So in this patient, which I don't know the exact percent, but we do see patients with LAM that have what we call a little reactive airway disease or asthma. So that combination may give the sense of a higher work of breathing. It's a combination, right? A little airway involvement and some cysts involvement in the lung tissue. So that work is definitely felt as uncomfortable breathing, even though your oxygen's fine. I would say for cold air, wearing a mask or a cold air, just if you're outside, you should really try a warming mask of some sort, even a little scarf, of those can affect how your breathing feels. So exercise, I have to say, exercise, pulmonary rehab data is very strong about decreasing sensation of breathlessness. There is something about not just conditioning, but desensitization, a little bit of each maybe. Learning some breathing techniques. But I think that's that cusp of that doing the uncomfortable breathing because it's a bit more work. And maybe the combination of the asthma with the, just, exercise, breathing retraining, warming air.
And there are a couple of questions here too. And I again, this kind of speaks to when you're kind of right on the edge. You do a 6-minute walk and you're fine, but then you walk for 15 to 20 minutes and you desaturate. Or, if oxygen supplementation is only prescribed when your saturation is below 89% at rest, how did you go about getting supplementation, right?
Yeah, so that's a very good question. It's actually something that there's actually going to be an ATS, American Thoracic Society group, looking at better standardizing exercise oximetry for exactly what you described. So we do sometimes walk patients up stairwells, which is not always safe or smart to do, but we do, to try and mimic their home environment. They're carrying things, for example. That's a thing we get while they're walking. So we do try and mimic at home as possible, as much as we can, but it's a challenge. But I would also, I think I don't want patients to panic when they hit 89. You're still very safe. This is not, especially if it's short periods. But it's uncomfortable, and I understand that. But I agree on the exercise. So they could ask that it varies per center. Can you walk me on stairs or up a grade, up a slight hill, or faster? Whatever it is that they feel will be more similar to their activities, what we call daily living at home. Yeah.
Right. Well, I know Kelly O'Toole Leonard, she said she was able to do a bike test with an ABG and to simulate it then to be able to show that with intense and longer exertion.
All tests, right?
Yeah. So there may be ways you could talk with your pulmonologist, right, to negotiate that.
Yeah. And it's actually helpful in general. We do that higher level if we want to make sure that it's just the lungs contributing to the breathlessness, or if there is a heart issue, like a little opening between the two chambers, or something we're not clear about.
Right.
But yes, that's kind of the catalog of testing. I mean, actually, at the NIH, Dr. Moss could put you on some fancy equipment up there and do it.
Get that test. Yeah. This I'm going to close with this question because it's something we hear about advertised. There's some cans available on Amazon that fit in your purse. These are those oxygen-like berths, right? So are those useful for keeping as emergency when people go out like shopping and things like that? Or what is the skinny on that?
My impression is no.
Okay.
Because I don't know. I've not seen one, and I don't know the technical stats on it. Like, is it one hit? It's not going to last, right? It's a one-time hit, is what I understand. A couple of breaths or something. That's going to be gone, and there's no long-lasting effect. So don't waste your money.
Got it.
I don't know. I should probably find out more about this, but I think what I've heard, because another patient brought this up in another setting, it's not long lasting. It's not going to, it might, I don't know if it will help for a few minutes, but no, that's not the answer. If you're getting hypoxemic while you're out shopping, then you should be wearing portable oxygen. Yeah.
Got it. Well, we appreciate you so much. I know, folks, if there are questions in the chat, I will go ahead and I'll look through those. And Susan has graciously offered to answer those offline if we need to. Dayton, if you want to write your information in the chat box, that would be wonderful. And we'll be able to get back in touch with you. So I want to make sure we've got time
I don't have a question. Sorry.
Yes.
My name is
Yeah.
Maya Flannery. I don't have a question. I wanted to
Yeah.
show you a device that I use. People were asking about being short on oxygen. So it's called a Pet Buddy. It comes in a little container like this. It was developed by Dr. Zafar here at UC. He's a pulmonologist here with a colleague of his. I was in his study. So it's this little gizmo that has either 3 or 4 holes at the bottom. And all you do is you put it in your mouth and you blow out. And what this does is it's like pursed lip breathing on steroids a little bit. And I have a lot of air trapping for my Lamb disease. And so I find this extremely helpful. I wear it, I use it playing tennis. I do it at pulmonary rehab. I do it walking. I do it sitting. I do it yoga. This thing is so helpful. So I just wanted to let people know that it's out there. The website is pepbuddy.com, pebuddy.com. Just look into it. I don't get anything for advertising this whatsoever. I just want to let you know. So I highly recommend this as a additional aid. And also for those people who are having breathlessness and are panicking, if you sit there and you breathe out in this, it will calm you down because you will be able to see that you can get air and the anxiety level comes down and you can breathe better.
Wonderful. That's Pet Buddy. Yeah. I've looked into that before. Susan, have you heard of that?
I have heard of it. I kind of, one of my other groups of patients, one of them showed it to me again.
Yeah.
Thank you. Yeah.
Yes. Thank you.
I had a friend, I had a co-patient at pulmonary rehab that just got one. She's really excited to use it too. So
wonderful.
Hopefully it'll help somebody else. Thank you.
Sure. Thank you so much. All right. So this has been so interesting and helpful. Thank you again, Susan, for taking the time to present both at LAMposium and then to come back and to do this for us virtually. We really appreciate that. We are so fortunate to have your expertise and care, as I said. So let's give a round of virtual applause for Susan. Thank you so much.
Thank you all. Yes. I always learn something from groups too. It's really great to have sharing of this information. It's good for all of us. Thank you for having me.
Thank you so much.
Okay,
all right. At this point in time, we're going to close at least the presentation portion of this evening. And I want to remind everyone of the importance of tissue donation in furthering LAM research. So if you are a LAM patient living in the US, if you're having an upcoming surgery of any kind, please reach out to the National Disease Research Interchange directly, or you can contact us at the LAM Foundation for more information. Donating is a simple process. And as you can see, even in this picture, we had a researcher at our recent LAMposium who presented on research that was done from lamb tissue donated. So exponential impact for a simple process. So a few quick calendar notes. Tomorrow at 1 p.m. Eastern Time is a follow-up webinar on portable oxygen concentrators. This is hosted by Running on Air, and you can register directly on their website. For those of you who had more specific questions on POCs, this would be a wonderful place for you to do that. Our next LAMposium in your living room will be Thursday, March 12th. Dr. Joel Moss and his team will be presenting on LAM protocols at the NIH. So we hope you will join us again in March and in the coming year for our additional LAMposium in your living room sessions. Thank you again for joining us. We will now stop recording.